Today's topic is diabetic ketoacidosis. What are the precipitating factors? Precipitating factors are infection, it may be infarction, maybe pregnancy, it can be cocaine, or it can be non-compliance to treatment. That is, when the patient is not taking the medication, if they have any drug abuse, if they are pregnant, any MI infarctions, any infections. These are the precipitating factors for DKA. DKA occurs when insulin levels, when insulins are very low, that is, they have deficiency. There is no insulin level, very low, or we can say complete deficiency, or there is excessive counter regulatory hormones, that is, there may be glucagon or epinephrine or cortisol. Okay, these will be high and insulin levels are very low. Okay, because of this, what happens? What are the symptoms? Symptoms can be nausea. What are they? Nausea, nausea, vomiting, thirst. Because why thirst? Thirst and polyuria. Why? Because what happens? Because of these things, glucagon, epinephrine and cortisol, there will be proteolysis. This proteolysis, because of this proteolysis, what happens? Uncontrolled hyperglycemia. When there is more glucose, that is uncontrolled hyperglycemia, osmotic diuresis will happen. Osmotic diuresis will happen. In diuresis, I think most of them knows what in diuresis, which volume will deplete, ECF or ICF? ECF. ECF volume depletes. Okay, and as you already know, because of decreased insulin levels, there will be increased CPT, calamine palmitoyl transferase, not that much needed, but as we already know, because of this, what happens? Fatty acids undergo beta oxidation in mitochondria. There is lipolysis will occur, right? Lipolysis occurs. Because of lipolysis, ketones appear, ketone body formation takes place. Because of this, ketosis occurs. That's why we have polyuria. Because ECF volume is getting depleted, we have polyuria. And nausea, thirst or polyuria. Remember, abdominal pain, SOB, shortness of breath. All these things will happen. So, what are the investigations you have to do? Investigations are was ABG, right? You have to know the anion gap, everything, right? ABG. And as we already know, these ketone bodies will be formed, so we have to check for urine ketones, right? Because of glucose hyperglycemia, what happened? ECF, ECF will be depleted, polyuria, and because of lipolysis, ketones are formed, ketosis, so we have to check for urine ketones. And the next series, next in ABG, what happens? It is HAGMA, that is high anion gap metabolic acidosis, right? These are the things. And what you have to do? We have to do RFT, renal function test. We have to see for electrolytes. These are the things we have to investigate. So this is the thing. Main important thing is treatment. We have to see about treatment, because this is the most emergency thing. It is an emergency. We have to identify the patient very early, and we have to give the care, because because of this DKA there will be huge loss of water, like almost 6 to 9 liters of water. 6 to 9 liters of water will be depleted in the body. So generally what we think, it is hyperglycemia. Like in casualty, in emergency, when we check for GRBS, it will be very high, more than 150 it will be. But what we think for hyperglycemia, people think of insulin. Insulin will be there, we have to give, but it's not the primary treatment. What we have to do is, first treatment, first we have to connect to IV lines. Very important, we have to connect to IV lines. Then we have to replace all the 6 to 9 liter of fluids. Okay, how you'll give this? There should be some systematic thing, right? Then you have to give first 3 liters over 3 hours. That is 1 liter for every 1 hour. Then after completion of 3 hours, after completion of 3 liters, then we have to give 3 liters over 9 hours. After this, we have to give 3 liters over 12 hours. Got it right? 3 liters over 3 hours, 3 liters over 9 hours, 3 liters over 12 hours. Okay, just remember, like 3 into 3, 9, right? 9 plus 3 is 12. 3, 3, 3, 6, 9. Okay, one more thing. See, here like we are giving 9 liters, right? For during this, we have to for every 1 liter fluid. Second. Okay, for every 1 liter fluid, what we have to give? We have to give 1 ampule of KCl. 1 ampule of KCl we have to give. Remember, in 10 ml we have 20 milli equivalents. Okay, for every, give 1 ampule after giving insulin start dose. For 1 liter fluid, 1 ampule of KCl, it is given after giving start dose. So let's see about the insulin. How we give this insulin? We give this insulin start dose. As I already told, no, start dose we give. Start dose. How start dose? What? How much? 0.1 U per kg IV. Okay, remember this. After this only, then followed by infusion 0.1 U per kg per hour. See, here thing is, example, if the patient is like 50 kgs, the patient is 50 kgs, and what you have to do, it is per kg, right? Then you have to give 5 units per hour. Okay, how is that? See, 0.1, right, for units per kg. So 50 kg person. 50 kg person means how much? 5 kg. 50 kg person means how much? 5 units per hour. Okay, now how we administer is 5 units per hour for 5 hours. Okay, later 3 units per hour for 5 hours. 1 unit per hour into, that is for 5 hours. So during all this phase, what we have to do is, we have to monitor blood glucose levels. Like for every hour, we have to check whether there is any increase, any decrease. Okay, we have to check. See, when the patient comes to the casualty, that will be their hypoglycemia, their glucose level will be so much, GRBS will be so much. I don't know, like it is more than 250 it will be there. So during this hourly monitoring, per hourly monitoring, when we are checking GRBS, we have to see if values are 200 mg per dl, then we have to switch switch from NS to 5% dextrose. Okay, from NS we have to switch to 5% dextrose. Okay, so like this, 5 units per hour 5 hours, 3 units per hour 5 hours, 1 unit per hour 5 hours. Here this can be overlap with subcutaneous insulin. Okay, this is a treatment for DKA. So once I will give a overview, okay, for DKA. First, what are the precipitating factors? Infection, infarction, pregnancy, cocaine or non-compliance. Got it right? Then next, what is the pathophysiology? Pathophysiology is what? It is absolute insulin deficiency and what? Counter-regulatory hormones will be increased. Okay, what are the clinical features? Maybe nausea, vomiting, okay, polyuria or thirst, so much of thirst, abdominal pain, so be. Okay, next, what are the investigations? We take ABG, right? In ABG what will happen? We have high anion gap metabolic acidosis and we have beta hydroxy butyrate level. I missed this one. This is a ketone, right? These levels we have to check. Next, urine ketosis, because ketone bodies are released because of lipolysis. Then CBC, then RFT, then electrolytes. So all these are investigations. Now what is the treatment? 2 IV lines. We have to replace 6 to 9 liters of fluid. Okay, 3 liters over 3 hours, 3 liters over 9 hours, 3 liters over 12 hours, and every 1 liter 1 ampule KCl after insulin start. How insulin? 0.1 U per kg IV. For 50 kgs there will be 5 units per hour. I will give for 5 hours 3 units per hour for 5 hours, 1 unit per hour 5 hours. This can substitute subcutaneous overlap with subcutaneous, and we have to monitor the blood glucose level. We have to monitor the blood glucose levels for every 1 hour. If it is near 200 mg per dl, then we have to switch from NS to 5% dextrose. That's it. Thank you. If you feel any way it's useful for you, please make sure you subscribe and like. Thank you. And if you want any topic, you can comment in the comment section. Thank you so much for your support.